our sort of winter webinar. And today we're going to take a slightly deeper dive into colorectal cancer surgery during the pandemic. We're going to look at the data from the first wave. There were quite a lot of different guidelines and rumors around that. We're going to unpick some of them today with hard data. So it's a pleasure to introduce the panel. I'm going to let them speak to them for themselves. But we've got Debbie. So Debbie Keller's dialing in from the United States today. Hello. Good morning, Debbie.
Hi, good morning. I'm Debbie Keller. I'm a colorectal surgeon and surgical scientist with clinical practice expertise in rectal cancer and pelvic floor. Was from Columbia University in New York and have just changed over to UC Davis in California. Welcome, and thanks.
Debbie's got up very early in the morning on West Coast America, so thanks for joining us.
Sure.
Over to Rohin. So Rohin Mittal is from Vellore in India. So welcome, Rohin.
Thank you, Anil. I'm Rohin. I am a colorectal surgeon. I work at Christian Medical College in Vellore in India. I am participating in some of this amazing work that's being done in global surgery, and I have a special interest in colorectal cancer. It's a pleasure to be here.
And so Rohin and Debbie are going to give us, after the data, they're really going to give us executive summaries of how they think we should be, or how we can use this data. Our two speakers today, Elizabeth Lee. Hi, Lizzie.
Hello, I'm Lizzie. I'm one of the surgical registrars from Birmingham, and I've been working closely with the Global Surgery COVIDSurg team, and pleasure to be here today.
And it's a pleasure to introduce Mary Van. Hello, Mary.
Hi there, I'm a surgical reg at the Royal London and a PhD student at Queen Mary University of London. I'm excited to have been with COVIDSurg since the beginning.
Good, and Mary's really led the way on our patient-facing material, which is all available in lots of languages on the website. So Lizzie, could you just put up that first slide for me, please? Okay, I think it's worth just thanking our funders who they're predominantly UK based, but they came forth at the start of COVID and provided us with the support we needed to launch the platform. And without them, it wouldn't have been possible. These are all patient-facing organizations who had patients at the end of all this, and all our data and research is really there to try and make things better for patients. So we're grateful to those groups. The network is big now. So the network from the first phase has over 50,000 patients. From the second phase, which is the COVIDSurg week, has over 150,000 patients in it, which we'll come to later. We've linked together thousands of hospitals and across hundreds of countries, and over 25,000 surgeons. And this network has provided the data surgeons are needed, but it will also last into the future. So you're going to hear today about cancer. The cancer project included 17 different cancer types across 10 oncological disciplines. But today we're going to take a deeper dive into colorectal cancer. So I'm going to hand straight over to Mary. Mary, over to you.
Thank you. So as you say, we're talking about elective colorectal cancer surgery and patients collected in the COVIDSurg Cancer study, particularly looking today at practice change with regard to anastomosis and stoma. Can I have the next slide? Perfect. So as I imagine most of the audience is colorectal today, anastomotic leak, significant complication and causes significant morbidity and mortality, including need for intensive care and longer hospital stays, which was a particular challenge at the beginning of the pandemic. At that time, we were diverting ITU capacity for COVID-19 patient care. Our anaesthetists were being redeployed, and so were our ventilators. And all of the changes together, as well as surgical juniors working in the COVID-19 effort, reduced elective operating capacity. And for those patients who were continuing to be operated, we really had some uncertainty about their outcomes and what would be the best course of action for those patients. Sorry. So quickly, the Royal Colleges released some guidelines, and they made recommendations including a cautious approach to forming anastomosis, recommendations toward diverting stomas and even stomas rather than anastomosis in some cases. But it was a little confusing, and surgeons were using best evidence and the guidance with their colleagues to make decisions for individual patients, and those were different in every environment. So we asked what was the actual change in practice in stoma formation in elective colorectal cancer surgery in that early phase of the pandemic, when really nobody knew what was the best thing to do. So we used the COVIDSurg colorectal data, which was prospective international multi-center cohort study data, including patients having colon and rectal cancer surgery with no suspicion whatsoever of SARS-CoV-2 preoperatively. And this data is limited because we finished on the 19th of April with a 30-day follow-up after that. So we really are looking at a special group of patients that we won't probably see again. And those 30 days, we recorded if there was any death, any anastomotic leak, if a patient were to contract SARS-CoV-2, if they went to intensive care, and how long their hospital stay was. And we managed to recruit 2,073 patients from 270 hospitals in 40 countries. So we really did get a broad view of practice in that short time window. And the results showed, of those 2,073 patients, approximately 60% were men. And then when we looked at age, the patients were slightly younger, with more patients under 50 and slightly fewer patients over 70. The ASA, slightly lower, with more patients operated of an ASA 1 or 2 and fewer patients with a higher ASA grade. And again, cancer disease stage, we were operating on slightly lower stage disease. So 62% were with stage 1 or 2 disease, and only 6 compared with almost 10% of stage 4 disease patients operated in that precious time period, where we needed to really be selective about which patients were being operated. 30% of patients had radiotherapy compared to slightly more in pre-pandemic period. And to note, this is the data from the ESCP cohort studies in 2015 for right side and 2017 for left side. Approximately the same number of resections were done according to location in the colon or rectum. But when we looked at anastomosis, compared with 76% stapled in the pre-pandemic era, suddenly 86% were stapled anastomoses during this early part of the pandemic. And we saw that more stomas were formed. This 34% of patients who had a stoma formed compared with a 27% prior to the pandemic era. However, only 4% of these stomas were what we call COVID stomas, so where the surgeon has reported a practice change due to the pandemic. So only 90% of patients, 90 out of 2,073 patients underwent a COVID stoma. So really that's quite a tiny change in terms of numbers that we were seeing. And of those 90 patients, 2/3 were end stomas and 1/3 were defunctioning stomas. And there was no significant difference in outcomes between normal practice and COVID stoma patients, with mortality of 1.1 or 1.9%, anastomotic leak in the region of 4 to 5%, and SARS-CoV-2 infection 4.4% in the COVID stoma patients and 3.7% in normal practice, but again, nothing significant. Critical care stay was not significantly different between the two groups, and whilst length of stay appeared to be shorter in those COVID stoma patients, it was not significant. We did ask surgeons what their reasons for creating COVID stomas were, and most commonly they reported that professional guidelines and the need to avoid complications that might require intensive care support were cited as the reasons. So really, we saw quite a small change in stoma practice, despite a lot of chatter about stoma practice change in those March and April months. And we saw that anastomosis probably was safe in the selected group of patients who were younger and fitter and with lower stage disease. Thank you. And a
Well done, Mary. Thank you very much. We're going to launch the first of the short polls. So, has your anastomotic decision making changed? How has it changed during the first pandemic wave? So that should pop onto your screens now. So Mary, quick follow-up question, one follow-up question, then we'll move on to the next presentation. So a small group of patients ended up having a stoma when they wouldn't have had a stoma previously. Small, but probably significant. Around you, do you think any of those patients are likely to have had their stomas reversed now, or will they get them reversed anytime soon?
Where we are, there was a lot of chatter, and I'm uncertain actually how many local COVID stomas were made, but it's difficult to get non-urgent surgery through still, and cancer surgery is prioritized over reversing those stomas.
Okay, same here. Thank you very much, Mary. We're going to go, so we can start discussing this as a whole. We're going to move straight on to Lizzie, who's going to now bring the second half of the data to us. So Lizzie, over to you.
Thank you, Anil. Thank you, Mary. Hi, everyone. My presentation is on anastomotic leak and the post-operative SARS-CoV-2. So what we knew already from the first analysis that we performed on patients with peri-operative SARS-CoV-2 is that, so these are the patients who had COVID, whereas the patients that we're looking at in this current colorectal study are ones that did not have pre-operative suspicion of SARS-CoV-2. The patients that did have peri-operative SARS-CoV-2 had a higher than expected mortality rate and a devastatingly high post-operative pulmonary complication rate, which was associated with a mortality of 38%. So the question is, what were the outcomes in patients who had elective colorectal cancer surgery during this period of time? It's a slightly different group, and we really would like to know what happened to them and how best we can manage these patients in the future. So when we analysed the outcomes from this particular data set, as Mary has described, we found that the 30-day mortality was 1.8% compared to the 1.1, which was in the pre-pandemic era. Anastomotic leak was actually overall lower during the COVID era, which rather than the 7.7% from the pre-pandemic era, which most likely reflects a degree of patient selection. And what we found was the post-operative SARS-CoV-2 infection rate overall in this elective group was fairly low at 3.8%. So we then asked the question, so who leaked? And there wasn't actually a huge difference between those that did leak and those that did not. But do bear in mind that those that did leak was a very small number. So firstly, males were more likely to have an anastomotic leak. But when we looked at the age, the over 70s was slightly more likely, ASA grade 3 to 5 was slightly more likely to leak, and a higher disease stage as well. When we looked at the type of operation that patients had, this was significant, and from a 3.6% risk of leak from the right side to a left side of 4.2, in the rectum, it quickly grew to 6.5, and any patient having a big operation, such as a subtotal or pan-proctocolectomy, had an 8.8% rate of leak. When we looked at radiotherapy as well, so remember the radiotherapy group were actually just the patients who had a rectal operation. Those patients that did have radiotherapy had nearly a 9% risk of leak versus a 5.3. So though this was not significant, it strongly signaled this direction that this was a risk and the numbers were quite small, and this is probably why this has come out as such. However, interestingly, when we look at patients who got SARS-CoV-2, those that got SARS-CoV-2 had a 20% risk of leak, anastomotic leak, compared to those that did not get SARS-CoV-2. So this showed quite a strong association. Then when we look at pick apart the patients who had anastomosis, so those at risk of leak, the mortality rate with those that had anastomosis and those that just had an stoma and no anastomosis was fairly similar. When we then look at the ones who had anastomosis and who had SARS-CoV-2 infection or no infection, this was again markedly more risky and higher rates of 30-day post-operative mortality with those that did have post-operative SARS-CoV-2, which very much reflects the first analysis done in the Lancet paper. When we looked at patients with no infection and no anastomotic leak, mortality was very low at 0.9%. Those that did have anastomotic leak but no infection had a post-op mortality of 8.2%, which, just to give some context, is very similar to actually the pre-pandemic era, perhaps a slightly higher. The pre-pandemic era overall mortality after leak was 6.6%. However, when we move on to those that did have a SARS-CoV-2, without a leak, their mortality was 15%, and with a leak, though the numbers are small, it is quite devastating, and post-operative mortality was 38%. So what we saw was that mortality rates showed an increasing relationship with anastomotic leak and post-operative SARS-CoV-2. And this was again reflected in those that didn't even have a chance of leak, those that had the stoma. When they got post-op infection, mortality rates went up significantly. So then we looked at this we plugged this into an adjusted regression model to find out which factors were the most that influenced 30-day mortality. Anastomotic leak and SARS-CoV-2 was very strongly associated with this. And just to give you some context, the adjusted odds ratio demonstrates how many times more at risk a patient is of death if they do have an anastomotic leak. And these factors were independently associated with post-op mortality. Again, patients who are older, male, were found to significantly have a higher risk of mortality, and also disease stage 4 as well, higher disease stage. And this data very much also reflects what we saw at the initial Lancet paper. So the take-home messages are, it is generally safe to operate on these patients, actually, these elective patients. However, there is a very small group who had a leak of SARS-CoV-2, and they are very high risk. So, and plus furthermore, SARS-CoV-2 infection poses and continues to pose a significant and universal risk for surgical patients. So the question now is, how can we protect and mitigate our patients against these risks? We firstly looked at cold surgical pathways, and when we looked at a completely cold surgical pathway, in other words, ITU, theatres, all of these areas were entirely COVID-free versus pathways where there was a mix, we found a consistent and independent indication of the benefit of a cold pathway. And this was particularly seen when there was a high background community of SARS-CoV-2 and also in high risk patients as well. When we also looked at swab testing for patients, pre-operative testing, we found that between no testing, swab testing, CT testing, or CT and swab, it was the swab only, singular swab only test that yielded the most benefit for patients. And if I can direct your attention to the right column there, what we found was that, so the numbers needed to treat represents the number of patients that you would need to deliver this test to before you saw one patient benefit. And we saw that the areas that will benefit the most are areas with high background SARS-CoV-2 risk and for patients having major surgery. So there are major benefits to be had for swab testing in selected patients. And what we have also done, is put together and compiled the first global policy report, which you are able to access freely, that details strategies and plans, with a variety of strategies and plans that you will be able to implement for a variety of different hospital settings to help us get through this period of the pandemic, and also long-term plans of how we can continue through to deliver good service to our patients. Thank you very much.
Okay, well done, Lizzie. Thanks very much. So two things before we move on to our executive speaker. First, can everyone see the results of the first poll? So about 40% of you actually had to make some change to your anastomotic practice, which is really interesting during the first pandemic. I would put myself in that 40%. I didn't exactly know what to do, and I made some decisions based around patients, but we'll explore that in a moment. The second thing, it is a pleasure to work with colorectal disease. This paper has now been accepted to colorectal disease, which is a really good journal for this paper. It's a collaborative authorship model for us again. So everyone who contributed will be listed on PubMed. That's not immediate, so please just bear with us, but everyone will get listed on PubMed. The Wiley group of journals, all their websites are down at this moment in time. So we were hoping to send around the final PDF, typeset PDF for you. And that's actually colorectal disease's new layout and new format is very good, but we can't do that at this moment in time, I'm afraid. But just before we move on, we'll launch our second poll. So how will you adapt your services during the second wave? So that should pop up. We're just going to go to our executive speakers before we fully delve into some of the. I am going to ask some hard questions, but we're just going to get a bit of an executive summary. And by executive summary, what does this mean for us in practice? How do we take this data away? What are the uncertainties? That's what the next half an hour is going to be about. To start us off, Debbie, I'm going to go over to Debbie, who's going to give us a summary of her views. So Debbie, over to you, please.
Sure. And just recapping, here we're looking at elective patients who didn't have any suspicion of COVID. And with that, it's important to note that this was also data until April, and testing was not widespread at that point. So even though we're including people that had CAT scans and people that had swabs, we were also going by clinical suspicion. And I think what we saw with this paper versus other papers is that our patient selection was much better. These patients had lower comorbidities, more ASA1 and ASA2 patients, more patients with stage 1 and stage 2 disease, over 60%. There's more neoadjuvant chemotherapy being performed and radiation, and comparable rates of critical care and ITU utilization compared with pre-pandemic. We were also using options available to get patients the therapy that we need. I think it's interesting that we saw higher rates of short course radiation in pre-pandemic. And with the better patient selection, we were able to perform almost 60% of these cases minimally invasive, which is on par with pre-pandemic, with actual lower rates of conversion to open than pre-pandemic. And this is ultimately going to lead to lower lengths of stay, so we can get patients out of the hospital faster and preserve the resources, which is what we really need. I think it's admirable that there were really a very small increase in COVID-stoma rates. But I think it's essential for us to know that when people were making stomas, it's because of their fear of using the ICU or ITU and the resources that we have in the hospitals. So when we put this into practice, we have to really know what the state of our hospital is, and we really need to test. Testing is critically, critically important. One thing in this that stays with me is that even though there were relatively stable numbers of stoma performed, there was a much higher rate of end stoma performed, which has a significant effect on the patient and on quality of life.
Thank you very much, Debbie. But just to allow us to interpret that from a different view, can I go straight over to Rohin for his summary, please? Rohin, over to you.
Hi, thank you, Anil. I think I'll echo some of things that Debbie said. I think this data is from very early on in the pandemic, where guidelines were being issued by many of the organizations. And at that point of time, COVID was a very novel disease. We did not know what effect it would have on our patients. Testing capacity was limited. We were expecting that the ICUs and hospital will be full, and there will be redeployment. And so the aim at that point of time was to try and operate on fitter patients, try to get patients out of hospital fast, and try and avoid complications at all cost. And therefore, the guidelines were issued. Since then, I think we've come a long way, and the data that we've produced here is just one bit of the jigsaw puzzle. We've seen a small increase in stoma numbers, overall 4.3%. But if you break the data down, right colon, it's only about 1.5, whereas for left colon, it's 2.5. But if you go to rectal resections, there's a 7.5% increase in stoma formation rates. And if you break that down even more, about 2/3 of them are end stomas. So patients are having a Hartmann type resection rather than an anastomosis. And the long-term implication of that is that they may, we do not know how the reversal will be or when the reversal will be. And I think that has a significant consequences on patients. The other thing that we've seen is that despite, being the stomas being formed, if patients do get a SARS-CoV-2 infection, mortality continues to remain high. And if they do have an anastomotic leak, the mortality rate is higher. So how do we use this data? How do we go forward? I think what this data has provided is one bit in the big jigsaw puzzle. We need to look at patients who were not operated, patients whose surgery has been delayed, and how do we deal with them? Two things that have come out from this data is, one, that an anastomotic leak leads to higher mortality. And the second is that if patients do develop a SARS-CoV-2 infection, then their mortality is much, much higher. And if they have a combination, then I think the outcome is the worst. And so we need to form a policy where we mitigate the risk of anastomotic leak as well as post-op infection. And I think these two need to be done at various levels. We need to do this at a patient level where we have to do testing. Testing is paramount. I think all patients have to be tested. We need to establish COVID-free pathways so that we can safely operate on these patients. We need to select our patients better. We need to select patients who are likely to not have a leak or withstand an anastomotic leak. We need to look into the local infrastructure, the hospital ICU capacity, the hospital pathways that exist, and at what stage of the pandemic the local hospital is. And I think each hospital will have to sort of look into everything like this and make a decision on which patients can go forward or not. But I think we need to prevent post-operative COVID infection, and we need to operate on we need to establish a risk for every patient.
Thank you, Rohin. So we've got some questions. I'm going to start with a question from the audience. And there are quite a lot coming in, which is great. We'll get to them. So Ali Yildirim has asked a tricky question. Why? Let's just focus on that small group of patients who had SARS and a leak. Did the SARS, we'll start with Rohin, then we'll go to Debbie. Can you hypothesize? Do you think the SARS contributed to the leak? Or what do you think there was a combined mechanism that led to the higher rate of death? What do you think is going on in that small but important group of patients?
That's a tricky question. I can't be sure, but I think it goes both ways. I think we are learning more and more that SARS-CoV-2 infection is a systemic infection rather than affecting only the lungs. And there's an associated coagulopathy. There is associated multi-system involvement. There may be microvascular involvement. We are seeing increased rates of mesenteric ischemia in some of our patients over here. So I think there may be involvement at a vascular level, which may be causing an anastomotic leak. Also, patients go on to ITU they they have multi-system involvement, and just the general debility also may sort of lead to an anastomotic leak. So I think it's a bit of both, is what my thought would be.
Debbie, following on from that, have you seen any differences in surgical patients and the physiology when they do have an established COVID infection?
Absolutely. I think that the inflammatory reaction that they get is much more profound with COVID. You really do see a multi-system organ failure SIRS response more than you would see otherwise with a leak. And you see the coagulopathy, which was something that we were confused by early on in the disease and understand much more. So it's a systemic problem and not just a GI problem.
And so there may be an element of chicken and egg, whether the leak came first or not. This is going to be a sick group of patients. On that theme, I'll ask everyone this question. We'll start with Lizzie. So on that theme, as future waves are coming, if you had a high-risk patient, so let's say someone, a male, bit older, limited exercise tolerance, but has a good quality of life, needs an anterior resection, I'm not going to ask you for very specifics. What I really want to know is what's going through your mind and how you're going to have a discussion with this patient. So Lizzie, the high-risk patient in the next phase.
What the data shows is that somebody, as you described, male, has some medical problems. They are the high-risk group. They will not do well if they suffer a post-operative anastomotic leak or if they have post-operative SARS-CoV-2. These are the patients that I would swab. I will make sure that we are able to deliver an operation in a clean and cold pathway so that we can optimize their outcomes and still deliver a timely cancer operation.
Thank you. And Mary, from a patient point of view, high risk, let's say you want to go ahead with surgery. What have you changed the way you're going to give these patients information?
Other than conversations with patients, which are becoming more and more online, we can augment these conversations with the patient resources that we've produced, both in patient booklets, but also for the other interested patients. We've summarized all of our research in lay summaries. And it's important for patients to have those booklets and resources tailored specifically for them. Do they know whether their pathway is cold or hot? And they may make the decision that they don't want to undergo that risk of surgery at that time and revisit that later if they're able to do so with their surgeon. I think that more than ever, we need to have really individual tailorized care.
Thank you. Rohin, so same question. I sort of delayed some patients who are considered to be moderate to high risk. Did you change your practice around patient selection in the first wave?
Yes, actually we did. I think the first step was to recognize that these patients are high risk and we have limited ICU capacity. What I have found is that just having an honest conversation with patients and explaining to them the risk, and making them understand that if they do develop a SARS-CoV-2 infection in the post-op period, the mortality can be as high as 30 to 35%. Many of them actually decide that they would rather have a stoma than the anastomosis. So in a rectal resection, we would undertake a Hartmann's type of operation. In the right colon, we may end up bringing a endoileostomy or a double-barrel stoma and tell them that we will reverse them in due course of time. I think patients are very aware of risks of surgery. There's a lot of information which is being given to patients through social media, through satellite television, through WhatsApp and various other things. So actually, patients do come and ask, and I think that's a way to go. Have a conversation. But for a high risk patient, I would err on the side of stoma rather than do an anastomosis, especially if we do not have a separate COVID-free pathway.
Debbie, I'm going to come to you, but I'm going to step slightly out of remit, and then we'll come back to Rohin with the same question. So we will see more data coming out of the COVIDSurg Collaborative on cancer, but around around me for the rectal cancers, we sort of had a gentle shift in how we were giving therapies. We gave more short course radiotherapy. So Debbie first, then Rohin. Stepping back and looking at the wider group of rectal cancer patients during that peak, did you spot any differences yourself?
We did. And it literally took a pandemic to be able to make short course acceptable in the United States. So we were doing short course, and then we were waiting the necessary time to decrease the complication rates that are written about afterwards and operating.
And so was short course in the US, was it less prevalent than during the pandemic? Is that right?
Absolutely. Absolutely. Even though it's acceptable in the NCCN guidelines, it's just not used. And part of that is because of the billing structures in the US.
And now, as things come and go, waves come and go, do you think short course is there to stay, or is it going to go and come? Or?
I hope so. You know,
Okay.
it's still TBD, but I hope so. I think it's better for the patients. And once we're waiting, it's, you know, no problem with the tissue planes. There's none of the edema that we had before the wait periods. And
okay.
I think it's beneficial.
So it's a bit of an untold story, unfinished story. Rohin, again, neoadjuvant therapies around rectal cancers and the pandemic. That's a complex area, but what did you guys do?
Yeah, I think we use a lot more short course. And again, like Debbie said, it took a pandemic for us to sort of accept short course more than often. So we used a lot of short course therapy, and with a long wait, some of these patients are coming up for surgery now. And I think this is going to be a very good cohort of patients, maybe for a wide international study to look at what happened to these patients. But yes, we wanted to decrease footfall in the hospital. So yeah. Yeah,
well, exactly. Same for us. We limited the long course because of footfall in the hospital capacity. We just did it, you know, there weren't the people around to be able to deliver that service. And actually that shifted our MDT more towards short course now as well. Rather, you know, we were always quite a strict MDT on long course, but now we're even stricter, which is a very interesting change. And I think you're right. I'd be interested to hear from people in the audience about whether we need to be doing something next year and looking at that group of patients globally and seeing how whether practices have maintained their sort of change. Whilst we're on this, can we just talk briefly about, we'll come to Lizzie. So prioritization for the second and third waves. The UK is about to enter a sort of third wave, or is it just a continuation of the second wave? I'm not sure. But how are you going to use this data to prioritize patients? If you've got younger patients, older patients, small cancers, big cancers, can you, I know it's a tricky question again, but does our data suggest that certain people should be prioritized over others, or when we've got limited resources, or should we continue as we were?
So it really does depend on the resources that you do have available. If you have the full remit, it would be an MDT decision, but it would be the most beneficial to operate on those patients who we know are going to get curative disease, curative surgery, and who will be able to have a successful operation. If you are able to deliver a cold pathway and also be able to tackle these more complex high-risk cases, eventually we do need to look after these patients oncologically as well. However, interestingly, we are currently in the process of analysing our next data set to answer these questions and to see how best we can manage these patients, how long we can wait before these patients go into danger as well, and to inform further practice as the pandemic continues.
So Mary, East London, diverse population, different levels of education and language. Do you think over the next year or two that you will see different presentations of colorectal cancer? Might these be earlier disease? Might it be more advanced? Will it present at all? Have you guys in East London have a feeling about what's going to happen?
I think already we are seeing disease presenting at a later stage. And there are some, in the UK at least, government campaigns to bring people presenting their symptoms a little sooner. I think it's a story that's too early to tell here.
but it's one we should perhaps be preparing for. Rohin, in your practice, have you yet had someone coming forward for? So we've had another. I'm asking a question from the panel. So Hina Khan and a couple of others have asked from the viewers. Have you had anyone come forward for elective surgery yet, who has either had a positive swab when you've seen them, or that they say that they had a previous COVID back in March? And if so, have you guys got a strategy for this yet?
So yes, so we have seen a reasonable number of patients who've tested COVID positive and are now coming for surgery. Some as as late as 3 months. But what happens is we are doing routine preoperative testing, and many patients are picked up asymptomatic. What we usually follow here is at least 2 weeks of quarantine, which they stay at home, quarantine at home if they're asymptomatic. And then we are waiting for about a week to 2 weeks more before we operate on them. So we operate on them about 3 to 4 weeks. But again, this is an area I think COVIDSurg week data will give us more answers to that. But what we've found is that about 4 weeks, 3 to 4 weeks post-op, they don't seem to have too many complications.
And Debbie, in the USA, you'll probably see these patients coming forth. Has it happened already, or are you going to get ready for it?
They have come forth, and we try to use the COVIDSurg data. It shows after waiting a month, there's significantly lower pulmonary complications and mortality data. What we're sadly seeing had curative disease coming in with incurable disease now from waiting and fear of coming into the hospital. And I think that's a whole other arm that we need to address, is the patient fear, and also the provider fear of telling people when you're low, moderate risk, it is safe to come in and have surgery.
I'm sticking with you, Debbie, on that point, because you mentioned this other group of patients who sort of, we have dealt with the group of patients who went forward for surgery. Mm-hmm. But do you think that there is in terms of colorectal cancer, do you think there's a different denominator, and who might make up that wider denominator, who might have had surgery, might not have had surgery?
I do. I do think that there's people that are asymptomatic with their masses because they're not obstructing, that are deferring surgery now.
Did you come across anyone, and the COVIDSurg Cancer study will unpick this, but I wonder if there's a small group of patients who had neoadjuvant therapy when they wouldn't normally have, and maybe had complete responses in the rectum. Do you think, is that possible, or do you not think we're going to detect those people?
I think it's going to be difficult to detect those people. In the US, it's such a strange mix of private and public payer systems, and it's really hard to find that data. It would be difficult to be reimbursed for doing something that's not standard of care. So for people that really aren't due to have radiation or chemotherapy, probably not so many that received it, but many more that are receiving it appropriately and doing watch and wait protocols.
So thank you. Rohin, I think we'll find a few from European practice who maybe had an unexpected complete response, and that will be really interesting to see. I don't know that for sure. We'll have to analyze the data as it matures. Did anything like that happen in your practice?
I think for some of our patients, our MDT decisions were changed, especially for borderline operable cases. So, in the pre-pandemic era, we would err on the side of operating, but during the COVID time, we actually erred on the side of giving them neoadjuvant therapy. And some of the high-risk patients, especially high-risk colon cancer patients, we ended up giving them some chemotherapy rather than operating on them. So yes, we will have a few of those patients.
Thank you. So I'm going to ask another contentious question, and it's about, for all of you, so it's about guidelines. I think a lot of guidelines came out during phase 1, and they were all done with the best intentions. I don't think anyone set out to write a set of guidelines to mislead anyone. People did their best under trying circumstances. But as guidelines go forward, we are all frontline facing clinicians, do you think, should we be recommending to organizations that guidelines in the future waves and future crises are all based on data, or do you think that those early guidelines helped us? So let's start with Mary.
Hi. I think that it's admirable to base everything on data, and at COVIDSurg we said our data-driven decisions, and we've tried to do our webinars with data every time rather than per se. But I think in March and April, with so much uncertainty about every aspect of our lives, it was nice to be supported in making a change to normal practice by a guideline which said consider, and it didn't demand. So I think that it was supporting the patient and surgical discussions that were happening with real earnest in individual places. So I don't think that non-data driven guidelines are what we want, but I think that was a good way of mitigating uncertainty and providing some support.
That's a really interesting view. So you're sort of advocating for an early set of principles and then add data in as we go, which is really interesting. Lizzie, did that reflect how do you feel about what guidelines should be doing in the next pandemic?
Yes, firstly, I completely agree with Mary. At the very beginning, when there was no data and this novel virus was something that none of us have encountered before, all the societies could do was to extrapolate using the best expertise that we had of what we should do to try and protect ourselves and our patients in the best way possible. But now that patient level data is emerging, a large scale data is emerging as well. As the pandemic progresses, it would be most beneficial for this to be based upon prospective, high quality, the best that we have, patient level data. And in that way, we can best inform not only our patients, use this for local and regional strategies and guidelines for different hospital areas, for different countries as well, rural university hospitals. And it's only with this sort of broad-reaching global data that can help this.
Debbie, too many guidelines, or do you need that many guidelines to make them regionally appropriate? Is it too aspirational to expect for a global guideline? Maybe that loses sensitivity. What do you think?
I think there are too many guidelines. I think there's probably a handful of guidelines that are excellent, and places that I've gone through all of this: AIS channel, Solid, SAGES, American College of Surgeons. And you can see some of the regionalism bias for me there. I say with the US guidelines for the most part, but these have been constantly changing with the evidence as they've come out, and have really helped us further our practice and educate ourselves and our patients. But otherwise, it's just overwhelming. You're just being hit by a tsunami of opinions.
Thank you. And Rohin, so with all the guidelines that come out, we are lucky to work in MDTs. Not everyone watching will work in an MDT. I'm aware of that. Did you come together as an MDT to make decisions, or was it left to the individual treating clinician?
So I think that's a very interesting question. Right in the beginning of the pandemic, when we were in lockdown and all elective surgery was stopped, we had some time on our hands, and actually as a colorectal cancer treating group, we sat down and sort of looked at a bit of evidence that was available and sort of formulated our own working principles as to how we should be treating them. Data was very, very limited at that point of time, but we had our own sort of a skeleton of a guideline that we used based on best available evidence and best practice at that point of time. Coming to guidelines, I think guidelines are important, and I think when we don't have data, we have to have guidelines on sort of a common opinion from experts. But then guidelines also need to evolve, and as new data keeps becoming available, these guidelines have to be evolving just as the pandemic is evolving. And I think it has to be regional, but we have to look at probably one leading organization taking on the role of providing guidelines rather than multiple small organizations in the same area.
I'm just going to give the results of the final survey. Then I'm going to ask each of you for your view on what this data means for 2021 and how we might end up using the data, or how you think things might change. So the question we asked from the last poll was, how have you adapted your colorectal services going forward? The top three answers, so 54% of you have changed the volume of patients. That's interesting. I suspect, we didn't ask it, I suspect that might be a lower volume, and we may see a rebound of that. Patient selection change, we've discussed that. I think most people ended up with some form of change in patient selection. And 29% of people adopted cold surgical pathways. these cold, COVID-free green pathways, we're doing some work across the network, and they are not unanimous. Unless you're in the right environment, they're not easy to implement. They do take resources, and not everyone has them. So we've got the data to say that they are better for patients. But so far, our work has shown that a maximum of 60% of people have managed to get a COVID-free pathway up and running. And so I think that's actually one of the toughest things to do, because it requires a lot of stakeholders and is difficult. So can we just go around? I'm going to ask you for your final view just before we wrap up. So Lizzie, 2021 and colorectal cancer surgery, what would you be prepared for?
I would be prepared to plan for the long term, look at the patient cohort, and be confident enough to continue on with colorectal surgery, but mindful of the high risk patients, and take steps to protect these patients who are high risk as best as possible, and have a vision and plan for even beyond 2021 also.
So make surgery as safe as possible. Mary?
Thank you. As Lizzie said, I would be mindful of the patient who is high risk, but be really thoughtful about talking to patients. And if it has to be via Zoom, maybe it means 1, 2, 3 conversations. Maybe it means a conversation with a family member on a different occasion. But making those decisions together.
Rohin, looking at 2021, minimally invasive surgery, is that back on the cards for you guys?
Yes, I think we are back doing most of our cases minimally invasive, but all patients are tested. I think looking forward, I think we will see a large number of patients. We will see advanced disease, and the way forward, I think, is testing, setting up cold pathways, sort of making joint decisions with patients on how to decrease complications, and trying our best to sort of prevent post-operative COVID infection. I think these will be the main things going forward.
Thank you. And Debbie, over to you. What do you think? Rectal cancer in 2021. How's that? What's that going to look like?
I agree with everything that everyone else said. I think that we really need to focus on risk stratification as well, to make sure that we can offer our patients the best outcomes. It's something that's not done as stringently as it should be. Hopefully it's going to look with more short course, and for patients that aren't getting short course, rehabilitation, I would hope would be more in the cards. I fear that's something that's fallen to the wayside with people sheltering in place and not going out and not seeing their doctors in person. And hopefully it's going to continue with not increasing the number of stomas unnecessarily. If people are making stomas because they're worried about infections post-operatively despite testing, diverting stomas and not ends.
Thank you. So we're gonna sort of wrap up there. The last poll popped onto screen, and that's how you're going to use this data. So people are going to use it, the top 3 answers to how you're going to prioritize patients next year, how you're going to speak to patients about risks, and preparing for future waves. And there is a larger conversation, not for today, about how we're going to prepare for future shocks, whatever those shocks might be, how we keep elective services going, and where elective surgery around the world takes place. 2 final comments are, on the 29th of December, we will be hosting another webinar on the COVIDSurg Week study. So many of you guys have taken part in this. It's got over 140,000 patients in it. It's been led by Dimitri Nepogodiev, who many of you know. And although this webinar won't present the results, it's intended to be almost a seasonal social to bring that network together and tell you where COVIDSurg Week is. So please look out for that. That's number 1. Number 2, we've launched, in feedback from what you guys have asked, a global trend survey. So that survey is looking at the provision of diagnostics and elective surgery around the world, and the information is trying to gather whether there needs to be a reset in elective surgery in some parts of the world as people struggle to get elective surgery back up and running. I don't think any of us want to see ourselves back in these problems in 3 or 4 years if something like this happens again. So to do that, you need to be signed up to the COVIDSurg mailing list via the website if you're not. But I'd like to thank all the speakers, Lizzie, Mary, Rohan and Debbie. It's really nice to have an international diverse panel and to understand how we can begin to digest that data. So thank you all very much, and we look forward to seeing you on the 29th. Thanks everyone. Bye-bye.